Assalamu alaikum. So today's lecture is about the cutaneous manifestations of the internal diseases. Till now, we were doing the manifestations of pure dermatosis, which may have internal involvement or features. Today, we are going to do the reverse. That is, those internal diseases that may present with some cutaneous manifestations and can be a sign of having that particular internal disease. Common cutaneous disease, the systemic diseases are diabetes, thyroid, adrenal, renal, liver, rheumatologic, and nutritional. We will do those that are included in your syllabus. First of all, and most important is diabetes mellitus. Approximately 30% of patients with diabetes develop skin lesions at some point. And overall, the prevalence of cutaneous disorder does not differ between type and type 2. Type 1 patients usually get more autoimmune type of lesions, and type 2 patients usually get more type of cutaneous infections. Now, cutaneous lesions usually appear after the development of diabetes, but sometimes they may be the presenting sign of diabetes. So if a patient is having a recurrent cutaneous disease, it's better to evaluate him internally as well. Now we divide the cutaneous manifestations of diabetes into four groups: skin diseases associated with diabetes, the cutaneous infections, cutaneous manifestations of diabetic complications, and the skin reactions to diabetic treatment. Necroboisis lipoitica. It is more common in women. It appears earlier, that is, the mean age is 22, and more in type 1 diabetics than in type 2. It begins as an oval violaceous patch and expands slowly. Advancing border is red. Central area turns yellowish-brown. Central atrophies, telangiectasia may be present and may lead to ulceration. It occurs bilaterally on the pretibial or the medial malleolar areas. It is not painful, may spontaneously resolve, resulting in residual scarring. Granuloma annulare. Appearance, ring of small formed flesh-colored or red papules. If localized, most frequently found on the lateral and dorsal surfaces of hands and feet, can spontaneously regress without scarring. Then the diabetic bullae. Approximately 0.5% of diabetics develop the bullae. Two types have been described: more frequent, the non-scarring lesions with intraepidermal split; less common, hemorrhagic bulla that heals with scarring, slight atrophy, and hemorrhagic subepidermal split. Trauma and microvascular disease may play a role. These are painless bullae on non-inflamed base that appear suddenly. Sterile clear fluid may be present in the bulla. They tend to heal spontaneously in 2 to 5 weeks. Diagnosis of exclusion: you have to exclude bullous pemphigoid, epidermolysis bullosa acquisita, porphyria cutanea tarda, bullous impetigo, erythema multiforme. Then acanthosis nigricans. It is seen in situations of insulin resistance. Besides in diabetes, it may be present in carcinomas, especially of the stomach, secondary to drugs like nicotinic acid, estrogen, or corticosteroids, pineal gland tumors, other endocrine syndromes, PCOS, acromegaly, Cushing's disease, hypothyroidism, and obesity, in which it is called as pseudoacanthosis nigricans. It may be related to insulin-binding, insulin-like growth factors, receptors on the keratinocytes and the dermal fibroblasts that stimulate the growth. Hyperpigmented velvety plaques in the body folds, mostly axilla and neck, can also present on the groins, umbilicus, areolae, submammary areas, and even on the hands. Then diabetic dermopathy, also known as shin spots or pigmented pretibial papules. Most commonly, this is the most common cutaneous manifestation of diabetes. Benign asymptomatic red-brown vacuoles on the shins, no treatment is required. Then the skin tags. These are the skin tags present anywhere, usually in the upper part of the body, neck. Vitiligo, very common because it's also an autoimmune condition. Diabetic eruptive xanthomas, seen in uncontrolled diabetes, hypertriglyceridemia. Sudden crops of firm, non-tender yellow papules with a red rim on extensors. Control of glucose and lipid reduction reduces the lesion. Then the skin infections occur in 20 to 50% of poorly controlled diabetes and more common in type 2. may be related to abnormal microcirculation, hypohidrosis, peripheral vascular disease, neuropathy, decreased phagocytosis and killing activity, impaired leukocyte adherence, and delayed chemotaxis. Candidiasis, fungal infections, most common type of infection in diabetes. Candida can present as candidal paronychia, that is the nail fold infection, inframammary candida or the intertrigal, then genital candida or vaginal candidiasis. Oral candidiasis, white curd-like material adherent to erythematous fissured oral commissure, more common in any age, even in childhood, then the angular stomatitis. Candidiasis in diabetes, the genital candidiasis, you can very clearly see the satellite lesions present around the main plaque. Again, the genital candidiasis. Then skin infections in diabetes, bacterial infections. They can be more severe and widespread in diabetics. Malignant otitis externa, caused by Pseudomonas aeruginosa. It is fatal in over 50% of patients. It can progress to chondritis, osteomyelitis, and bacterial meningitis. Bacterial infections in diabetics, erythrasma, sharply demarcated erythematous patches, upper inner thighs, axillary toe web spaces, inframammary creases, caused by gram-positive Corynebacterium minutissimum and identified with Wood's light as coral fluorescence under the Wood's light. Then insulin hypertrophy because of the recurrent insulin injections. Then insulin lipotrophy because of the recurrent insulin injections. And we cannot say which patient will develop lipohypertrophy and who can develop lipoatrophy. Then cutaneous manifestations of diabetic complications, foot ulcers. Peripheral neuropathy leads to unnoticed trauma. Vascular complications may lead to ulcers and complicate the ulcer healing. Then risk of amputation goes up 8 times once these develop. Next, we come on to the thyroid hormone and the skin. Thyroid hormone plays a pivotal role in the growth and formation of hair and sebum production. Thyroid hormone stimulates epidermal oxygen consumption, protein synthesis, mitosis, and determination of epidermal thickness. There is increased cutaneous blood flow and peripheral vasodilatation. So we can understand that if thyroid hormone is impaired, reduced, or increased, all these will be affected. Hypothyroidism in the skin. Skin is usually warm, moist, and smooth, best assessed on the inner aspect of arm and over the chest, facial flushing, palmar erythema, hyperpigmentation, especially palms and soles creases. Buccal pigmentation doesn't occur, which differentiates hyperthyroidism-induced hyperpigmentation from Addison's disease, which involves the pigmentation, buccal area and mucosa as well. Then hair is fine, friable, and hair loss may be excessive. History of early graying, hyperhidrosis, particularly of palms and soles. Plumber's nail and hyperthyroidism. You can see a concave contour and distal onycholysis, especially on the ring finger. It's non-specific, may also be seen in hypothyroidism in addition in psoriasis after trauma and allergic contact dermatitis. Then, scleromyxedema and hyperthyroidism. What is scleromyxedema? It results from accumulation of hyaluronic acid in the dermis, accompanied by large fibroblasts. And in this, clinically, numerous firm white, yellow, or pink papules on face, trunk, axilla, and extremities may develop. Similar picture, sort of chicken wire appearance. Similar picture. Then Graves' dermopathy. Pretibial myxedema in 0.5 to 4% of patients. Then late manifestation accompanied by ophthalmopathy. Presentation varies from puty orange appearance to extensive infiltration, most often bilateral, asymmetric, raised, firm plaques or nodules, varying from pink to brown, sometimes with woody induration. Can appear anywhere, arms, shoulders, and head. Histologically, the process involves dermal accumulation of hyaluronic acid. Basically, in this, there are pretibial fibroblasts, which are the targets for antithyroid antibodies. And they, in turn, cause subsequent activation of the fibroblasts to secrete more hyaluronic acid. And Graves' dermopathy may be treated with topical steroids, intralesional steroids, IV pulse steroids, or immunoglobulin, IVIG. Thyroid acropathy in Graves' disease. This includes a triad of digital clubbing, soft tissue swelling of hands and feet, and periosteal new bone formation. May also be accompanied by exophthalmos and dermopathy, which is called as diamond triad. May occur in Hashimoto's thyroiditis and Hurtle cell adenocarcinoma. Then hypothyroidism. The skin is all opposite to hyperthyroidism findings. Skin is cool, dry, and pale. Pallor results from cutaneous vasoconstriction and increased deposition of water and mucopolysaccharides in the dermis, which alters the refraction of light. Hypohidrosis may lead to palmoplantar keratoderma. Carotenemia from decreased hepatic conversion of beta carotene to vitamin A gives yellowish hue to the skin, especially of palm soles and nasolabial folds. Hair is dry, brittle, coarse, partial alopecia, loss of hair from lateral one-third of eyebrows, called as Hertog's sign, lateral superciliary madarosis. Then hair growth slows down, the proportion of telogen hair is increased. These changes normalize with normalization of thyroid hormone levels. Nails are brittle, grow slowly with purpura, easy bruising, wound healing is impaired, diminished levels of clotting factors may manifest as purpura. Hypothyroidism faces with generalized myxedema. Generalized myxedema, characteristic skin signs occur as a result of deposition of PAS positive dermal acid mucopolysaccharides, especially the hyaluronic acid and chondroitin sulfate in the skin. Skin is non-pitting with a firm waxy appearance, swollen lips, broad nose, microglossia, puffy eyelids. This can also be seen on the dorsi of hands and feet. Carpal tunnel and facial nerve palsy may occur due to nerve entrapment. Congenital hypothyroidism or the cretinism, mixed edema, yellowing or carotenemia or prolonged jaundice, pronounced clavicular pad of fat, coarse, dry, brittle hair, persistent long lanugo hair on the upper back, shoulders, and extremities, hypothermia, poor nail growth, delayed eruption of deciduous teeth, retardation of mental and physical development, and delayed milestones. All this is very important, which can be reversed when thyroxine is given. Then thyroid replacement therapy rapidly reverses many of the cutaneous features of hypothyroidism with gradual disappearance of excessive dermal mucopolysaccharides. Then association between cutaneous and thyroid disease. Vitiligo, right? But this is basically the autoimmune side. Vitiligo may be present connective tissue diseases like dermatomyositis, SLE, scleroderma, generalized granuloma annulare, chronic urticaria, melasma, chronic mucocutaneous candidiasis. And therefore, patients with idiopathic chronic urticaria and angioedema should therefore be screened for thyroid autoimmunity. Then other association, alopecia areata, rapid onset of total hair loss in a sharply defined, usually round area. Excuse me. Regrowth begins in 1 to 3 months and may be followed by loss in the same or other areas. Pemphigus foliaceus, pemphigus vulgaris, herpes gestationis, bullous pemphigoid, dermatitis herpetiformis, all these bullous disorders may be present with thyroid disease. Then renal diseases. It can be divided into three: the signs of end-stage renal disease, signs associated with dialysis, and signs in renal transplant patients. End-stage renal disease or uremia, cirrhosis, pruritus, pigmentary alteration, nail changes, hair changes, acquired perforating disorders, bullous diseases, and all, calciphylaxis. Cirrhosis, most common cutaneous abnormality, predominantly over the extensor surfaces of the forearms, legs, and thighs. The abdomen and chest may show fine scaling. Hypervitaminosis A may be due to a reduction in size of eccrine sweat glands and high dose of the diuretics. Uremic pruritus. Incidence 50 to 90% of patients, forearm back पे common होता है. Cutaneous manifestations of pruritus include excoriations, prurigo nodularis, and lichen simplex chronicus. Reasons: decreased transepidermal elimination of pruritogenic factors. Then hyperparathyroidism, hypercalcemia, hyperphosphatemia, and elevated histamine levels. How do you treat this? Moisturizing creams, capsaicin. Then physical treatments like UVB light, parathyroidectomy. Systemic medications include sedating antihistamines, cholestyramine. Alternative therapies include acupuncture and homeopathy. Pigmentary changes, pallor, anemia. Yellow hue due to carotenemia and nitrogenous pigments, urochromes in the skin. Then brownish black hyperpigmentation on the sun-exposed area and can be attributed to retention of the chromogens and deposition of melanin in the basal layer and superficial dermis due to failure of kidney to excrete beta melanocyte stimulating hormone. Then other treatment methods, sunscreens, sun avoidance measures, and clothing are advised for these pigmentary changes. Then purpura ecchymosis may also develop due to defects in primary hemostasis like increased vascular fragility, abnormal platelet function, use of heparin during dialysis. These are the main causes of abnormal bleeding in these patients, and dialysis treatment partially corrects these changes. Calcific uremic arteriolopathy, that is calciphylaxis, deposition of deposition of calcium in abnormal locations due to abnormally high levels of parathyroid hormones, and crystalline calcium pyrophosphate is deposited in the skin, fat, and the arterial walls. And the condition is associated with a high mortality, particularly when the skin of the trunk is involved. Acquired perforating dermatosis. These are pigmented papules up to 1 centimeter in diameter with a central keratinous plug and perforating because they cause transepidermal elimination of altered dermal substances. And this is significantly more prevalent in diabetic patients. Excessive scratching, diabetic vasculopathy, dermal necrosis, all these result in elimination through the epidermis. Extensive surfaces are more commonly involved. Bullous disease of dialysis, syndrome of cutaneous fragility and blistering, sun-exposed skin, most often on the dorsal hands, resembles porphyria. Plasma porphyrin levels are normal or only minimally elevated. This is the differentiating point to distinguish between porphyria and bullous disease of dialysis. Nephrogenic fibrosing dermopathy, scleroderma-like skin condition, and usually spares the head and neck, which is most common finding in early finding of scleroderma. Nodules and contractures can be seen, and skin biopsy shows fibrosis. The uremic frost. This was a frequent finding in pre-dialysis era, and blood urea nitrogen levels of more than 250 to 300. The concentration of urea in the sweat is increased, and after evaporation, there is a deposition of urea crystals on the skin surface, just like salinity on a ground. And when there is evaporation, only the saline is left, giving it a white, salty covering. The frost consists of white or yellowish coating of urea crystals on the beard area and other parts of the trunk. Nail changes. Lindsay's nails are the half and half nails, very common for findings of renal pathology. Others are polyonychia, subungual hyperkeratosis, onycholysis, Mees lines, Merkes lines, splinter hemorrhages, and the Bewes lines. This is due to transfusion-dependent patient on long-term hemodialysis. Several uremia-related cutaneous disorders are visible. Pigmentary alterations are present. Large bullae are present, which look like porphyria cutanea tarda. Can be due to porphyria cutanea tarda, or if the porphyrin levels are normal, then bullous disease of dialysis. And the Lindsay's nails are also present, the half and half nails. Yellow nail syndrome is a triad of yellow nails, lymphedema, and respiratory tract infection. Hair abnormalities, sparse body hair, and diffuse alopecia with dry, lusterless hair. Decreased secretion of sebum, chronic telogen effluvium. Drugs like heparin, statins, and antihypertensives may also cause hair abnormalities. Then liver disease. Chronic liver disease and hepatitis B and C. Chronic liver disease, most common find jaundice because of the raised level of bilirubin and diffuse hyperpigmentation. Spider angioma, spider nevi, nevus areneus. Pinpoint to up to 2 millimeter, mostly on the drains, skin drained by superior vena cava, small arteriole with elevated tortuous radiating capillaries. Presence may indicate an increased risk of bleeding from esophageal varices, and abundant cutaneous spider angioma may be present, showing signs of advanced chronic liver disease. Then palmar erythema, exaggerated mottling or well-defined hypothenar erythema that later spreads to fingers and rest of the palm, gynecomastia because of the hyperestrogenemia. Chronic liver disease, pruritus, recurrent purpura, xanthoma striatum palmare. Multiple xanthomas may appear as yellowish plaques covering large areas on skin in palmar creases. Then ascites, which leads to stria distensae, Dupuytren's contractures. Chronic liver disease may present with clubbing, longitudinal ridging, thickening, brittleness, total leukonychia. Total leukonychia, whitening of the entire nail plate except for a narrow band present distally. Muherkes lines, in which there are multiple parallel transverse lines, and the Terry's lines. Then hepatitis C. The cutaneous manifestations of hepatitis C are three: porphyria cutanea tarda, lichen planus, and the necrolytic acral erythema. This is porphyria cutanea tarda, vesicles and bulli on sun-exposed areas and scarring with milia, hypertrichosis, fragile skin with sclerodermoid changes. Anti-HCV antibodies are present in 2/3 of these patients. Hepatitis C serology should be part of the routine investigation in patients with PCT. Then lichen planus associated with lichen planus, especially in mucosal variety, generalized or long-standing LP. Purplish pruritic polygonal papules, as is seen in lichen planus. We have already done this. Necrolytic acral erythema starts as erythematous papules and sometimes blisters that coalesce into well-circumscribed dusky areas with the scaly erosions. Then hepatitis B, about 30% present with urticaria or present like a serum sickness picture because of the circulating immune complexes associated with 5 to 7% cases of polyarthritis nodosa. Then systemic lupus erythematosus. Malar erythema, discoid plaques or psoriaciform erythroderma, photosensitivity, alopecia, and mucosal ulcers, Raynaud's phenomenon, periungual erythema. This is malar erythema, also called as commonly butterfly rash. Mucosal ulcers are very common. Alopecia is very common. Annular psoriaciform macules and patches and plaques present on the upper part of the body, especially upper back. Annular psoriaciform macules and patches, you can very well appreciate the psoriaciform lesions, annular psoriaciform lesions with the central clearing and the scaling on the border. Annular psoriaciform macules and patches. Then periungual erythema. Periungual erythema may be present in various systemic connective tissue disorders. Then the paraneoplastic syndromes. These are basically findings that are present due to underlying malignancies. This can be divided into papulosquamous, like acanthosis nigricans, acquired ichthyosis, and lesser trilate sign, pityriasis rotunda, tripe palms. Lesser trilate sign, characterized by the abrupt appearance of multiple seborrheic keratosis associated with adenocarcinoma of the stomach or colon, squamous cell carcinoma, lymphoma, and leukemia. This is a picture of multiple eruptive seborrheic keratosis. Eruptive seborrheic keratosis is very common in elderly without any reason as well, but if it suddenly erupts and there is weight loss or other signs of cachexia, or you think there is some issue related to malignancy, then it has to be investigated for CA, stomach or colon. Then the tripe palms, acanthosis palmaris, thick and velvety palms, 90% associated with internal malignancy. Tripe palms are frequently seen in conjunction with acanthosis nigricans, but acanthosis nigricans can occur without any acanthosis palmaris. This is a picture of acanthosis palmaris. Then in the erythematous paraneoplastic varieties, dermatomyositis, erythema gyratum repens, multicentric reticulohistiocytosis, Sweet's disease, necrolytic migratory erythema. Sweet's disease is sudden appearance of red tender lumps or plaques on the skin, usually on the limbs or neck, sometimes elsewhere, and it may follow internal cancer, usually of bowel, genitourinary organ, or breast. This is a picture of Sweet's disease. Neutrophilia, it's also called as neutrophilic dermatosis. Then for the bullous variety, paraneoplastic pemphigus. In the miscellaneous, generalized granuloma annulare, carcinoid syndrome, hypertrichosis lanuginosa acquisita, Trozius syndrome. Very rare rapid growth of long, fine lanugo-type hair, particularly around the eyebrows, forehead, ears, and nose. Most commonly affected area is mouth. Some patients have extensive involvement that includes the trunk, axilla, and extremities. Palm, sole, scalp, and pubic regions tend to be spared because there is no hair growth on the palms and soles, and scalp and pubic hair already have the terminal hair. We are talking about the vellus hair. You can appreciate in this picture, the nose is covered with fine hair, and this is most commonly associated with lung, breast, uterine, colorectal cancers, lymphoma, and bladder cancer. Trozius syndrome, migratory superficial thrombophlebitis. Lesions appear as inflamed reddened lines or lumps in the fat under the skin. 50% of patients with Trozius syndrome have an associated cancer, usually pancreatic, then adenocarcinomas and the lung cancers. So this was all about the cutaneous manifestations. And I put this topic in the end just to, so that you, since you have done all the diseases, all the dermatoses in the previous lectures, you can understand the different types. If you did this lecture in between or early, you would not know some of the dermatoses that we've already done in the previous classes. Thank you.